Damage control resuscitation. This is a really interesting concept. So until recently, like the last couple of decades, when a multi-trauma patient came to hospital, they go up to surgery for definitive repair. And it seems really intuitive and obvious. So if someone's got multiple injuries, they'd stabilize them in the ED as best they could, send them up for surgery, and the person might have 7-8 hours on the table, where the surgeons just worked to fix everything and had a pretty high mortality. It was discovered that better outcomes were achieved if the patient was, stabilized in ED, got some bloods running, had their airway controlled, stuff like that, and then they went up to surgery just briefly, just so that the surgeons could correct the surgically correctable bleeding. Give them a quick emergency laparotomy, open them up and clamp off what they could, ligate what they could, and only have them on the table for maybe an hour, and then send them off to ICU. In ICU, they'd stabilize them further and they'd correct all the physiological insults. So correct the acidosis that goes along with trauma, warm them up so they weren't cold anymore, correct the coagulopathy so they didn't bleed so much. And they'd take a couple of days to do that. And then when the patient was physiologically stabilized, then they'd send them back to surgery for the definitive repair. So for the long multi-hour surgery to correct, the broken bones and all the cosmetic things that were gonna have to happen. And they found that there were much better outcomes from that. So that sort of damage control surgery has been extrapolated down to the ED and into the pre-hospital sector in the form of damage control resuscitation. So it comprises of two things: a combination of minimum volume resuscitation and managing the lethal triad in trauma. So we know that the body deals better with anemia than with hypovolemia. So your body prefers it if there's less red blood cells in the blood, but if the blood pressure is still maintained, then it prefers having plenty of red blood cells but no blood pressure. So we can do that with just saline. Saline is just a volume expander, and even though it dilutes the blood, the body deals reasonably well with that sort of anemia, and that's better than letting the person become completely hypovolemic and hypotensive. But too much crystalloid is not great. As I said, it's just a volume expander and has several unpleasant side effects, such as that dilutional coagulopathy, dilutional coagulopathy, where every time you give someone saline, you're thinning their blood. They have less clotting factors, less plasma, less red blood cells, and more of just this salty water taking up the space. And it's also cool. We keep saline at room temperature, which is quite a lot cooler than your body's internal temperature. So the sweet spot for this, the compromise, is the concept of minimum volume resuscitation. That's where you do give crystalloid fluids, but only to maintain a radial pulse or a mean arterial pressure of 65. Now remember, mean arterial pressure is diastolic blood pressure plus 1/3 of the pulse pressure. And the pulse pressure is the difference between the systolic and the diastolic blood pressure. Now the reason that we go for those two markers is that at a MAP of 65 is about when you have a radial pulse, and at a MAP of 65, all of the organs in your body are getting enough blood flow to survive. But anything over that is a bit superfluous. That's just going to increase bleeding, increase coagulopathy for no real benefit. If you go below that, you start to hypoperfuse your organs. Your kidneys are the first to go. So if it helps you remember 65, kidneys alive. Now the lethal triad in trauma is a combination of hypothermia, coagulopathy, and acidosis. So when we go to a trauma patient, we do DRA, BC, DE, we expose them, remove their clothes, get an IV, give them some fluid, move them into the air-conditioned ambulance, and all of these things contribute to the patient getting cold. So you don't have to cool that much. 34 degrees, you only run at 36.5 normally. You get down to 34, you start to get pretty coagulopathic, which means your blood's not going to clot properly. And that's obviously associated with increased mortality. So what we need to do is give minimal fluids, that minimum volume resuscitation, knowing that the fluids in the ambulance are going to be a lot colder than the patient's blood, and apply blankets. So it can be, cotton blankets, space blankets. Ideally, you want those self-warming blankets. They can take 5 or 10 minutes to heat up. So get them out early when you realize you're going to need it, and give it a bit of time for that chemical reaction to start. And this is the one that is the most upsetting for us as paramedics, is we need to keep the ambulance hot. Now, if you're at a trauma, you're going to be sweating, particularly if it's in summer. You're going to be unpleasantly hot. You're going to want to get to that ambulance and crank the aircon to make yourself more comfortable. You actually need to do the opposite, crank the heat. If you're not pouring out sweat in a multi-trauma, you're not doing the patient any favours. You've got to keep them warm if you want to improve their outcome. Now, when your cells become hypoxic, they switch from aerobic to anaerobic metabolism. And the byproduct of anaerobic metabolism is lactate, which is acidic. Now, if enough lactate goes into the blood, that acidosis ends up resulting in acidemia, so acidic blood. And this acidemic blood doesn't clot properly. So what we need to do for that pre-hospitally is maximize oxygen delivery. So what blood is getting to the tissues still is saturated with oxygen. And we need to make sure that we're maintaining the carbon dioxide down at normal level, 35 to 45. We don't want the patient to become hypercapnic, because although lactate and hypercapnia produce acidosis in different ways, we certainly don't want to stack a hypercapnic acidosis on top of a lactic acidosis. And we want to minimize normal saline again. So normal blood pH 7.35 to 7.45. The pH of saline is 5.5, so it's very acidic. So if your body can tolerate that if you just give a bit, no problem. But if you're giving a lot, you start to make the patient quite acidemic. And this is what it all comes back to, coagulopathy. So the clotting cascade relies, you have platelets and you have fibrinogen, but there's a whole stack of chemical markers that help them do their job called clotting factors. And these are finite. You only have a certain amount of them in your blood. They can be totally consumed, called a consumptive coagulopathy in major trauma, because there's so much bleeding. But even if they're not consumed, giving saline disrupts the ratios of everything in your blood, because you're adding all this salty water as a volume expander. But if they're imbalanced, they also stop working properly. So we want to avoid that dilutional anemia where we're giving too much saline. We also want to avoid the acidosis and hypothermia. So we need to administer fluid to minimum volume resuscitations, keep these patients warm, and call ahead to hospital early, pre-notify them so that they can get the massive transfusion protocol ready, which includes plasma, which will include some of the extra clotting factors.